Good morning. I'll speak about secondary rhinoplasty. The natural sculpturing of the nose during secondary rhinoplasty is the common goal of every rhinoplastic surgeon. Even for the most experienced surgeons, rhinoplasty remains the most challenging of all aesthetic surgeries. The aim of the study is to assess secondary rhinoplastic surgery on patients by presenting the functional and aesthetic techniques and evaluate the result of the surgical intervention. Between 2000 and 2014, 1,242 secondary rhinoplasty were performed. Most of them are female. The mean age is 26. I do open rhinoplasty for the most of them under general anesthesia. And I always do SMR, submucosal resection of the septum, because I use the cartilage of the septum for the graft, and I always do turbinectomy, inferior turbinectomy. Septal, auricular, or costal cartilage and fat graft reconstruction was also performed. So you see, we can get from the septum a huge amount of cartilage. Also, this is a turbinectomy. Normally, a lot of doctors say that when we do like this turbinectomy, we have problems after, like crust and others. I think the best is a good, if they wash very well their nose, they don't have any problem. This is a fat, and you can sculpt your cartilage, and you have a lot of, it will help you to reconstruct your nose. This is a shape you can have for the columella. You can sculpt your cartilage. Really, cartilage in secondary rhinoplasty is like oxygen. So if you don't do cartilage graft, don't do secondary rhinoplasty, because you always need cartilage. And sometimes I use the bone of the inferior turbinates. It's very important when you don't have a lot of cartilage and you need to enhance the volume of your nose. It's important sometimes to use the bone of the turbinates. And because you are ENT, so it's very easy. This is some type of reconstructions. You can do what you want by, you can put here for the tip of the nose, columella, etc. When you have a thick skin, it's important to have a lot of layers to enhance the dorsum of your nose. Concave alar cartilage. So these are different shape of reconstructions. So in this study, we have 13 different category of secondary rhinoplasty. Patient functional results were then evaluated using a questionnaire, like smell deterioration, not improve, improved. Nasal obstruction deterioration, not improve, improved. For the aesthetic evaluation, the independent observer reported highly satisfactory outcome of the majority of cases in our studies. So photo numbers and the evaluation. So first, the nasal tip deformity. When we do a closed rhinoplasty, even if we don't touch the tip of the nose, a lot of time we have a deformity of the tip of the nose because of the shrinking of the injuries inside the nose. So what is important is to do an open rhinoplasty to see, to visualize your cartilage and to adjust the edges of your cartilage, and sometimes you need to put over the cartilage some very thin cartilage to camouflage your defect. Also the same, protrude, open rhinoplasty to adjust the tip of the nose. Short noses. Short nose is a big problem because when we have, I believe, when we have a redo rhinoplasty, there is two important things. First, the skin. The skin allowed us to do the operation or not. If the skin is healthy, we can do the operation. Second, the cartilage. If we have cartilage, we can do the operation. In these cases, it's important to touch the skin to see if the skin is elastic or not, and to see if we have cartilage. So we do open rhinoplasty, and what is important is to dissect all the tissue of your nose and pull them down. You see, a very short nose. So I did open rhinoplasty, I dissect all the skin, all the mucosa, sorry. I pull them down, I do reconstruction, I add cartilage, and I did a traction, down traction. I will show you how. Sorry. The same, very short nose. So when we have a short nose like this, I do a graft of the dorsum, because you know your nose start here. When you do a graft, it will start up, so it will, you gain in the length of your nose, of the nose. See? So in this case, I add cartilage to the base of your nose, to the caudal part of the nose, and I fix it very well. When you have a short nose, I fix very well the cartilage. If you don't fix the cartilage, it will shrink, and all the tissue will shrink. So a lot of time I do a traction by external traction, and I let this for 15 days, and it will give us good results. Pick nose deformity. You have two types. The skin type, when you have skin type, I do graft of the dorsum and graft of the tip of the nose. So your skin will be, sorry for my bad English, stretch. This is the cartilage. Nostril deformity. When you have a nostril deformity, it's important to open to see the cartilage and to add cartilage on the defect. In this case, it's important. In all my secondary rhinoplasty, I do graft of the columella, because the columella is the base of your nose. It's the balance of the nose. It's important. And from the when you do the columella, you have 90% of your problem are saved. Then graft of the alar cartilage. Saddle nose. Saddle nose, you need to do cartilage graft of the dorsum. Also, sometimes several layers, especially in man. (108) residual cartilage or bone bumps. This is easy. You take off the bone and you have a natural. This rhinoplasty is after SMR. Sometimes when they do SMR, you have this problem. The dorsum will go down. Deviated nose. Deviated nose is a big problem. A lot of cases, when they do the rhinoplasty, special plastic surgeons, they don't check the septum. So it's important because sometimes you have straight nose. When you take off the bump, you don't see this deviated septum. You will see it after the operation. So it's important to check the septum. And sometimes it's too difficult, especially when the septum is too thin. So it's too malleable. Even if you do a graft, it always, so it's important if you can take a long graft and to do spreader graft. And in these cases, you can do asymmetric spreader graft. For example, you put 2 layers this side and a very thin layer the other side to adjust the deviated nose. The same spreader graft. It's important to check, to always check the caudal part, the spine, nasal spine. A lot of time when we finish our operation, you don't take attention to this part, and we see it after the operation. So it's important to, I always do a dislocation of this part when it's deviated. Pinched nose and prominent type. In this case, it's important for me to do open rhinoplasty because the alar cartilage is too prominent, and the only way to diminish the length of the columella and the alar cartilage is to cut and to reposition, to do reposition of the alar cartilage. Sure, spreader graft, pinched nose, spreader graft. Flat nose, especially flat nose, especially when you have a thick skin. So it's important to do a lot of layers to push your skin. Columellar deformity, it's a big problem because, like I said, the columella is really the base of your nose. So when I have a problem in the columella, it's important to put a hard cartilage, a straight hard cartilage, to have a good result and to fix it. Inverted V, a lot of time we have the inverted V. It's important to do osteotomy and spreader graft. Overprojected nose. It's not too much overprojected, but people at our times, they ask always better and better and better. And even for a little projected nose, they want perfect noses. This one is a droopy nose because the problem of the columella. I saw one bilateral internal canto steering. Strange, I don't know how it happened. So, all patients reported significant aesthetic and olfactory and respiratory improvement because we did always spreader graft, SMR, and turbinectomy. The aesthetic results was good. For the discussion, some people, this patient came to me, she wanted to do rhinoplasty. I examined her, I told her, I do open rhinoplasty. She told me I don't want to do operation. So I did injections. So sometimes we see people, we thought it will be the best to do, for example, open rhinoplasty under general anesthesia. And sometimes the result could be good with a simple injection, fat injection or hyaluronic acid injection. So, big problem sometimes with injections. You can have like these scars. So when we do injection, it's better to do it deep, not superficial. This one, after a very little defect on the nose, I did a little injection, and you see I have necrosis, but then the result was good, because when you have a little necrosis like this, we have happy ending. This is a big problem. This is a patient who came to me. Sometimes we did a lot of things. We think that it worked. He came. He is a cocaine-man. There is no septum. There was no septum. So I operated him, and I opened the columella, and I put a graft. Then after, I had little necrosis of the columella. Little necrosis and necrosis of all the columella. So, you have to pay attention when we have cocaine-man, the vascularization of our skin. Our enemy is the skin. When we have a problem with the skin, we have a big problem. So in this case, we must reoperate him to do a flap. Before, he was operated 3 times. I think they did for him flap from the nasogenial part. So now, I think I will do for him a flap from the frontal flap or Washlow flap from behind the ear. So pay attention for the vascularization of the nose. At the end, what is important and good is a fat graft. Sometimes we have this defect. With a fat graft, you have a very good result and long-lasting result, because it's a graft. In conclusion, preoperative evaluation, a complete dissection of different anatomic elements, identification of nasal respiratory obstruction, and meticulous reconstruction will give us a good functional and aesthetic satisfaction. Thank you very much.
Thank you both.
This one is best.
Thank you. Can we take comments, questions? I'll start with you, sir.
Thank you very much for a very nice talk.
Thank you.
I just disagree with you on one point. You tend to have in your standard practice to do a turbinectomy all the time in the standard. I would just disagree with you. I think you're an ENT surgeon. I did my fellowship with Kennedy 6 years ago, and never do. In our department, we had plenty of complications. Even people nearly died of turbinectomies.
Died?
Yeah. And we don't do turbinectomies. It's not functional. And I just wanted to know why. What's your view? Why are you doing turbinectomy?
Yes. Sorry, where do you live?
I work in Liverpool, England.
I don't know, because I always do for all my patients, not total turbinectomy, let's say subtotal turbinectomy. Because I think when we do rhinoplasty and the opening of the nose will be a little bit narrow. So when we do turbinectomy, subtotal turbinectomy, I learn the patient how to wash very well her nose, not to sniff very hard and strong, because when they sniff very hard and strong, they create bleeding inside and scratch and bad smell and other. I told you, trust me, 90% of the patients, they have no problem after 2 weeks. Some other patients, I have to wash their nose in my clinic and to learn them how to wash. And really, we have a good result with. Maybe the weather in my country helped them the humidity maybe help them to have good result. But we have a lot of studies. Some people say it's not good, some people say it's good. I'm used to do subtotal turbinectomy and I have good results. And the people to whom I don't do turbinectomy, sometimes I do cauterization of the inferior turbinates. They came after with nasal obstruction. They don't breathe really very well. Sometimes I do luxation. Always. I don't know. In my hands, I have good results.
Can I ask a question?
Sorry, there was a hand that was there. Yeah.
Excuse me, what do you mean by subtotal turbinectomy? You leave the anterior part or you remove it?
Yes, you have your turbinate like this.
Yeah.
So you can cut from I cut really at like this. So I let a little part of the turbinates.
So because it's the anterior part is the most important for the internal nasal valve.
Sorry.
The internal nasal valve, it's part of it, it's the anterior part of the inferior turbinate. So when you take it with you, so you are disturbing the internal nasal valve. So all the patients, whenever you have a turbinectomy, when you have partial or subtotal, they have the nasal obstruction sensation. Because the air is going to be moving around, it's not dilated well. So this is the comment I was just
Yes, sure, when you do turbinectomy, the physiology of the breathing from the nose change, but even when you do rhinoplasty, all the physiologic change. So we try to find what is the best to have the good respiration. Till now, I told our colleague, till now, I tried sometime not to do turbinectomy. Then after I said to myself, I must do. I don't do total, subtotal.
But you are familiar with turbinoplasty. You take a lab and you take out the body part and keep the mucosa. So
yeah, maybe it's better. I don't do this, but maybe it's better to take off only the bone, maybe.
So I have one more comment. You said about submucosal resection. I don't mean by submucosal resection as the same old procedure
Of the septum.
Septoplasty.
Of the septoplasty.
If you septoplasty, it's well known, but submucosal resection, it's something obscure. Nobody's doing anymore, and it's considered as a crime now.
Submucosal? Submucosal resection of the septum.
If you do, it's septoplasty, right?
Yes, septoplasty.
Yeah, that's what I want to clarify. Submucosal resection is.
No, it's septoplasty. No, it's septoplasty.
Sure, that's it.
Yeah, thank you.
Can I ask?
Yeah.
It was an excellent presentation.
Thank you.
I really admire the way you have conducted various methods. They are very, very difficult, actually, as a matter of fact. One thing that has come to my mind, the septal cartilage, using the septal cartilage in various places, we have been also using septal cartilage. The chances of necrosis are too many. You see, instead of using septal cartilage, normally what we do is we use iliac crest, bone from the iliac crest, and then we have a very good result. What is your view about the, have you come across the necrosis of the septum or by using the septal cartilage?
Necrosis of the septum.
Yeah.
If you have perforation from the both sides, you have necrosis, some necrosis in the septum. We tried not to have this perforation, but even in primary rhinoplasty, I always do septoplasty, and I take the cartilage and I put cartilage on the dorsum to separate my skin from the bone. So I have better feeling when you touch the nose. It's smooth, and it will stay between the bone. It's better not to have the skin immediately on the bone. I always do septoplasty, and when I do the septoplasty, like you see in sorry, in one of my photo, I let an L-shaped cartilage to maintain the nose. Sometimes, if the cartilage is not thick, is not hard, after the operation, you see when the patient do like this, a little bit, it tilt. Then when they do like this, it tilt a little bit, but there's no problem with the support of with the nose.
My question is, do you prefer using cartilage, septal cartilage for your rhinoplasty than the iliac crest, the bone? Because the septal cartilage has got two problems that we have seen. One problem is that normally there is septal necrosis sometimes occurs.
If I have septal cartilage, I prefer septal cartilage.
Thank you.
Thank you.
Any other comments? Thank you very much.